Hi everyone, this is part 3 of respiratory disorders in chapter 32, and we're going to be talking about intrathoracic airway disorders. The first one we're going to talk about is bronchiolitis, also known as an infectious asthma, an asthmatic bronchitis, wheezy bronchitis, or a virus-induced asthma. We know that this disease can cause inflammation, necrosis, and swelling of the respiratory epithelial cells in the lining of the airways. It's seen in viral illnesses, primarily RSV. It simply starts as upper respiratory symptoms, cough, chorea, rhinorrhea. Respiratory distress starts gradually. There's usually a low grade to moderate fever, and the child will have a decreased appetite. On physical exam, you'll notice that inflammation of the mucous membranes in the nose, redness of the eyes, pharyngitis, otitis media. There can be elevated respiratory rate. There can be retraction. There can be expiratory wheezes and fine to coarse crackles. And there can be varying levels of respiratory distress. Diagnostic studies should be based on the history and physical. Chest x-ray is not needed unless symptoms are severe and you're needing to rule out pneumonia. Evidence-based guidelines from the AAP are strongly against routine chest x-rays, including those in previously healthy infants with mild RSV. Routine virologic testing is not recommended unless the child is hospitalized. Differential diagnoses could include asthma, foreign body aspiration, airway irritants, GERD, pneumonia, etc. So management of this condition, evidence-based practice published by AAP no longer supports bronchodilators as an option for infants or children with bronchiolitis because of the risk associated with its use. Nebulized hypertonic saline is suggestive for hospitalized infants only. Antibiotics are not used. Management is more supportive care with hydration and antipyretics. Supplemental oxygen if SATs should fall low. Monitoring for fluid intake and nasal suctioning to help keep airways open and avoid deep airway suctioning. The first 48 to 72 hours after the beginning of the cough are most critical. Apneic spells are common in infants. Prolonged apnea and uncompensated respiratory acidosis and prolonged dehydration are the most seen complications. These kids can have a tendency to have bronchial hyperreactivity that can last for many years. Prevention is key. Synagis, which is the RSV specific monoclonal antibody used for little ones for protection, is important, and educating caregivers about limiting exposure. It's also important to educate parents about avoiding child care centers whenever possible, avoiding tobacco smoke exposure, and scheduling RSV prophylaxis vaccines when indicated. Okay, now let's move on to foreign body aspiration. Symptoms are going to be dependent on the nature of the foreign body, where it's located, and the degree of obstruction. With laryngeal foreign bodies, there's usually a rapid onset of hoarseness and a croupy chronic cough. You have to have a raised suspicion for a foreign body aspiration, especially with children that have that sudden episode of cough, unilateral wheezing, and or recurrent pneumonia. For a tracheal foreign body, you may appreciate a brassy cough, hoarseness, shortness of air, and even some cyanosis. With a bronchial foreign body, most objects are aspirated into the lung based on anatomy, and when obtaining your medical history, you may even reveal that there was a forgotten choking or gagging episode. These kids may have blood-streaked sputum. On physical exam, there may be limited chest expansion, decreased vocal fremitus or atelectasis. You may notice crackles, rhonchi, or wheezes. Clinical suspicion is going to lead your diagnosis. So if that is decided, inspiratory and forced expiratory chest x-rays and chest fluoroscopy may be useful in identifying any radiolucent foreign bodies. Management includes being referred to pulmonary for a bronch. If the object is removed via bronch before permanent damage occurs, usually recovery is complete. If there's been secondary infections and bronchial spasms, those should be treated. Complications include, if the foreign body was of vegetable matter, that there could be a vegetal bronchitis, and this is characterized by sepsis-like fever, shortness of air, and cough. And if it's been there for quite a while, suppuration or pus may have collected. You may have a lobar pneumonia, intractable wheezing, or status asthmaticus. Anticipatory education regarding prevention is most important and should be part of the well-child supervision guidance. Parents should be educated on high-risk foods such as whole carrots, nuts, popcorn, and hot dogs. And young children need to be supervised when eating and having small objects in their mouth. Next, let's talk about bronchitis, which is a nonspecific inflammation of the bronchioles, and it can be classified as acute or chronic. Common viral agents that are associated with bronchitis are the influenza virus, RSV, adenovirus, and the parainfluenza virus. As we said, it can be acute or chronic. On your history, you'll note a dry hacking cough, low substernal discomfort. You may notice that the child complains of burning in the chest. There may be a family history of asthma, cystic fibrosis, infections, irritants, history of prematurity, GERD. Acute bronchitis is usually preceded by a viral infection. It's associated with inflammation of the large airways, and with that there can be destruction of the cilia. This illness may be also associated with pharyngitis as well as rhinitis. And although the virus is the most common cause of acute bronchitis, due to weakened tissue, secondary bacterial infection can occur. On exam, you may find that, as we talked about, rhinitis, a low grade or no fever, nasopharyngeal infection, conjunctivitis, coarse breath sounds. X-ray is not routinely done, and here are your other differential diagnoses. Management includes supportive care, analgesias, hydration, antivirals. If it's influenza, cough suppressants are not recommended. Bronchodilators are not recommended. But if it is chronic bronchitis, depending on the underlying cause, bronchodilators and steroids may be beneficial. Complications may include otitis, rhinosinusitis, pneumonia, and chronically ill children. Next, let's talk briefly about valley fever. And I'm going to butcher it, but I believe it is coccidomycosis, which is caused by a fungal spore causing a primary pulmonary infection. Usually kids are asymptomatic or have an acute illness. It's associated with erythema multiforme and erythema nodosum. Clinical findings in infants and kids include fatigue, weight loss, cough, headaches, chest pain, bone pain, neck stiffness. On physical exam, you may notice fever, crackles, skin abnormalities. Serological testing is going to provide key information. The response of the IgM detected by the EIA test is helpful in establishing the diagnosis. Management includes antifungal medications for high-risk kids. Indications for hospitalization would be those kids that there's concern that there's disseminated disease involving the CNS that's not responding to oral fluconazole and may require IV amphotericin B, and also if the patient has severe pulmonary involvement or low O2 levels. Prevention is most important in immunocompromised little ones, and they should avoid activities that might expose them to aerosolized spores in certain parts of the world's the Southwest U.S., Mexico, Central America, and South America. Let's talk about non-bacterial and bacterial pneumonia. So we know that pneumonia is a lower respiratory tract infection that is associated with fever and respiratory symptoms. In a lobar pneumonia, which is your typical pneumonia, it's usually bacterial. An atypical pneumonia has patterns of consolidation that are not localized, and that's usually caused by a mycoplasm. Viral pneumonias usually set the child up for bacterial pneumonias, and then you can also have pneumonitis, which is lung inflammation. On your history in neonates, it's important to get a history of group B strep or C trichomonas infection in the mother. You want to assess if there's been any prenatal drug use or lack of prenatal care. With C. trachomitis pneumonia, the patient may be afebrile. In infants, you may notice a slower onset of respiratory symptoms, and it's important to note whether the mother was exposed to TB or has any HIV status. In children and adolescents, you want to obtain that immunization history, travel history, and their TB status. Know if they've been exposed to anyone that has been sick recently. Could it possibly be a foreign body? Has there been a history of a mild upper respiratory infection? Is there an abrupt high fever? You may also see restlessness, shaking, chills, apprehension, shortness of breath, and some pleuritic chest-type pain. On physical exam, you may note respiratory distress, apnea, and some tachycardia. There can be nasal flaring, grunting, and retractions. Especially in neonates, you may hear fine crackles. There may be dullness on percussion or diminished breath sounds. If there's concerns for bacterial pneumonia, you may see fever, hypoxia, and lethargy. There may be splinting against the affected side, and there could be a pleural effusion noted. If it's a viral pneumonia of concern, there may be wheezing, there may be a downward displacement of the liver or spleen. Diagnostic studies include chest x-ray, blood cultures if symptoms fail to improve. There could be a variety of rapid tests for viruses such as influenza to rule those out. Differential diagnoses are going to be made based on age, signs and symptoms to help distinguish between viral or bacterial. You could have bronchiolitis, foreign body, pulmonary abscess. There could be a right lower lobe pneumonia that may be present with abdominal pain. Could be an acute appendicitis. Most of these children are managed as outpatients. And if you look on page 826 on table 32.7, it gives more information about the variants in the pneumonia microorganisms. And then on page 827, box 32-2 gives criteria for hospital admissions for pneumonia based on age of the child. Management is mostly supportive care with antipyretics, hydration, and rest. Antibiotics are only if bacterial pneumonia suspected. Guidelines for outpatient and inpatient treatment for bacterial pneumonia based on age and pathogens are found on page 827 in the book. Most kids recover fully from pneumonias, although the cough may last for several weeks, but prognosis is good. There can be several different complications that you can see there. Next, let's talk about cystic fibrosis, which is a multisystem genetic disorder which causes chronic obstructive pulmonary disease. It can cause GI disturbances and exocrine dysfunction. The autosomal recessive genetic disorder results in thickening of the mucus, and then this mucus thickening can target organ damage in the lungs and the exocrine system. In the lungs, there's an airway depletion which can lead to ciliary collapse and decrease of the mucociliary transport. And ultimately, this mucus obstruction can cause chronic inflammation and infection. In the exocrine system, the pancreas, the liver, and the intestines, these thickened secretions can lead to malabsorption of fat and protein and can result in pancreatic insufficiency. life expectancy for these kids is increasing, and there are new therapies that target the genetic defect to increase the lifespan. Clinically, you will find pulmonary-wise chronic lung disease, inflammation, thickened mucus, dysfunctional mucociliary transport, obstruction, and chronic infections. There can be a chronic cough and sputum production. There may be progressive disease, which could lead to respiratory failure and death. And in the GI system impacting nutrition, there can be in infants a meconium ileus, pancreatic insufficiency, rectal prolapse. There can be thick fat-laden stools, failure to thrive. There can be vitamin deficiencies, and there can be intestinal obstructions. In the liver, there can be biliary cirrhosis, jaundice, ascites, hematoemesis. Endocrine-wise, there can be recurrent pancreatitis, diabetes. There can be vitamin D deficiency, which can lead to osteoporosis. Reproductively, there can be delayed sexual development and male sterility. Diagnostic tests include newborn screening. The diagnosis of cystic fibrosis is made on clinical features and laboratory testing, and the gold standard for diagnosis is the sweat test. Another test is a genetic analysis for the CFTR mutation. Management includes treatment regimens at a cystic fibrosis accredited center with a multidisciplinary team. This slide gives a little bit more information regarding certain treatments for pulmonary and for GI. And then replacement of vitamins and endocrine managing diabetes. Lastly, I'm just going to let you look at this slide on pectus deformity. You can see more in the book, and that is going to be the end of chapter 32. Thank you.